These are things that we're going to be talking about. One sec, let me just minimize that. So introduction, what is heart failure? What are the treatments? When do patients require admission? And how do we manage it? So this is me, Dr. Akash Doshi. I'm an ST3 or medical registrar in endocrinology and diabetes and in general internal medicine. And I've completed a couple of qualifications there. So the first thing is, what is heart failure and pulmonary edema? So focus on heart failure. The heart failure is basically when there is damage to the heart, which means that it's not working properly, or also the heart can be so stressed that it doesn't work properly. So that's when there's extra pressure on the heart. And there's a bunch of different causes, which are showcased here on the right. But ultimately, we break them down into primary heart failure, where the heart is the thing that's broken, or secondary heart failure, where there's those kind of other pressures on top of it. In primary heart failure, we're looking at things like ACS, so acute coronary syndrome or a heart attack. That's probably the most common. But another very common one is valve disease, so aortic stenosis. Basically, if the valves are narrowed or they're not working properly, that creates a lot of backflow in the heart, again, damaging it. Arrhythmias, so when the electrical system or when the muscle system in a cardiomyopathy or the sac surrounding it in pericardial disease aren't quite working, that can also mean that the heart doesn't beat properly. In secondary heart failure, it's all the other kind of pressures that can go on top of the heart. So lung diseases can increase the amount your heart has to work to push blood into the lungs. And so that can cause a lot of pressure. Diabetes and hypertension can quite easily damage parts of the heart, causing diabetic or hypertensive cardiomyopathy. Thyroid, so for example, hyperthyroidism, when the thyroid gland is overactive, can put a lot of pressure on your heart, making it beat harder, faster, and against a much higher blood pressure. And then there's finally alcohol, which can also be quite toxic. The important thing to know is that heart failure is basically a constellation of symptoms for when your heart isn't working properly. So heart failure isn't the diagnosis per se, it's basically the consequence of what has caused it to become dysfunctional. And so part of when you're looking at somebody with heart failure, you're not just looking at them and thinking, yes, they've got heart failure. You're also thinking, what's the cause of that heart failure? Heart failure itself is the inability of the heart pump to pump around the amount of blood needed. It's either a bit too weak and therefore can't pump the blood out, or it's a bit too stiff, which again means that it can't pump the blood out. As a result of that, it results in the accumulation of fluid around the body. And that fluid can be distributed either in the legs or in the heart, depending on what part of the heart's not working. If it's the blood going into the left ventricle, then it's everything before the left ventricle. If it's the blood going into the right ventricle, then it's everything before that. And so left ventricular failure will tend to cause pulmonary edema because it's the blood from the lungs that's oxygenated going into the heart to go around the rest of the body. Vice versa, the blood that's returning into the right ventricle for it to pump, if the right ventricle is not able to beat it out properly, it backflows, causing fluid everywhere else in the body, classically the legs. And as a result of this fluid being in the wrong place, and the fact that the heart isn't working as effectively at doing all the things it needs to, you feel tired, breathless, and you're unable to manage your daily activities. Heart failure is separated in two entities. Actually, it's separated into three, but really it's, for the context of this talk, we don't need to talk about the whole huge range of heart failures. We split it into two, which is heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Think of it like a balloon. So in heart failure with reduced ejection fraction, essentially you blow up the balloon, but when the air is trying to come out, it doesn't come out so well. Essentially, the walls are really floppy, and so they aren't able to push back and push all that air out. That happens when the balloon's very overinflated for a long period of time to the point where the walls become thin and damaged. In heart failure with preserved ejection fraction, it's that the balloon is so stiff It's like when you're trying to blow up a balloon for the first time and it's really difficult to blow up. In heart failure with preserved ejection fraction, the walls of the heart are so stiff that it makes it difficult for the heart to fill properly and also for it to eject blood properly. But because ejection fraction is the amount of blood that is pumped out, essentially because the amount of blood going in and filling the heart is less, the ejection fraction is the same. It's just as a percentage of the amount of blood in the heart, it's a lot lower. The amount of blood is a lot lower, even though the percentage is the same. Why does it matter whether it's heart failure with preserved ejection fraction or reduced ejection fraction? Overall, it's really important if you are a heart failure specialist of some sort, or changing around the medications of patients with heart failure. That's because heart failure with reduced ejection fraction, there's lots and lots of trials that show that lots of different medications help. In contrast, heart failure with preserved ejection fraction, where again, the ventricular walls are very stiff and so the heart is not filling properly, there are limited treatment options that actually help. The treatment options only really help with the symptoms. They don't help change the kind of prognosis. But in either circumstance, for the average person, whether the heart failure is preserved ejection fraction or reduced ejection fraction, it doesn't really make much of a difference. There's still very much a similar risk of developing things like pulmonary edema and peripheral edema. And so in terms of the history, examination, investigations, and imaging, it really doesn't change much. And so in the history and examination, you're looking for shortness of breath on exertion, particularly for orthopnea, which is where you get breathless when you're lying flat. You might find that the patient states that they've been using more pillows than usual when they sleep. They may also describe paroxysmal nocturnal dyspnea. That's when they wake up in the middle of the night, really short of breath, really gasping for breath, and they need to get up for that to feel a bit better. And they'll describe edema. Classically, that edema is in their legs. You'll also arrange to have some blood tests. What you're looking for on the FBC is anemia or infection. On the U&Es, you're looking to see whether their renal function is disturbed. Liver function tests, because some of the medications might impact your LFTs. Electrolytes are particularly important, particularly because of your sodium and your potassium, which may be altered by your treatments, and that will come within your U&Es, and a CRP again for infection. The specific blood test is BNP, and BNP is very, very good. Essentially, it's produced by a stressed heart. And what it does is when the heart is stressed, BNP will be produced. What BNP does, unfortunately, is stresses the heart out further. And so that essentially trying to push the heart to beat harder, to work harder, because the body's like, well, the heart's not working so well. Maybe it just needs a bit more of a push. When it does that, the heart gets a little bit more of a struggle for the heart, and therefore it produces more BNP. That means the BNP values go up very quickly. As a result, if the heart is not stressed, the BNP will not be up. BNP is a very, very good negative test. If the BNP is normal, the patient pretty much does not have heart failure. And if the BNP is positive, markedly positive, you can be pretty sure that the patient has heart failure. This is a great, great test. And it's often the test that we'll use first line before we go on to imaging to confirm exactly what kind of heart failure it is. Is it that preserved ejection fraction that we were talking about, or is the ejection fraction reduced? We'll also want to organize some investigations for the underlying cause. Is it something to do with the heart, so primary heart failure, like a problem with a valve, or there's scarring from a previous heart attack? Or is it that the patient's diabetic or has high blood pressure or thyroid problems? We'll then want to start some treatment. As I alluded to in the last slide, essentially with heart failure, the issue is that the moment somebody develops heart failure, it's a vicious cycle. The body interprets heart failure as, oh my gosh, I've not got enough blood flowing around. And so what it does is it pushes the heart to work harder. It pushes the heart to beat harder, to try and produce more blood and help the blood flow around the body increase. And so all of our treatments work by reducing the work of the heart, because we know whilst in the short term, the patient will feel a lot better and the heart's working harder. Essentially, you can't keep that going in the long term. And so patients who, if the body is left to its own devices, what it will do is it will pressure the heart so much that it fails quicker and quicker and quicker. Our medications take the pressure off the heart to try and help prolong and reduce the amount of damage that happens to the heart over time. So the drugs we use, the first line drug we use is a beta blocker. The beta blocker slows the heart down, reducing pressure. ACE inhibitors or angiotensin blockers, what they do is they again reduce the pressure on the heart. They work on, so the body is trying to push up the blood pressure, the body is trying to push up everything, and the ACE inhibitors and angiotensin receptor blockers reduce all of this. Yes, as a result, the blood pressure will go down, but that's okay. And so a lot of people will get worried when the blood pressure goes down all the way to 85 systolic, because in any other circumstance, we'd be very worried if a patient had that lower blood pressure. But actually, with angiotensin blockers and ACE inhibitors, we're aiming for to really control the blood pressure. And so we'll continue up titrating the medication until around about an 85 systolic. Any more, and the patient tends to be symptomatic. If the patient is symptomatic, we might split the dosing to try and again give that maximum dose that we can to that patient to improve their long-term mortality. And nowadays, we use a different medication called Entresto. That has an angiotensin receptor blocker, but in addition to that, it's got something that mops up the BNP that we talked about on the last slide. Then there are diuretics. Diuretics don't improve the mortality. What they do is they help with the symptoms. So they help get rid of that excess fluid. And so patients feel a lot better with them. There are also other treatments that are available if the ejection fraction is very poor. And that's why it's important to get that echo and grade how bad the heart failure is. And so let's showcase all of this so that we understand it a bit better with our lovely Beryl. So you're called to see Beryl, and you might be seeing Beryl in primary care. You might be seeing Beryl as a result of attending a call that she's done to the ambulance service, or Beryl might be in the emergency department with you. But essentially, the principles are the same. So here's Beryl Freeman. She's a very, very sweet old lady. She's 72, and she comes to you complaining of shortness of breath and some leg swelling. She's got known heart failure, and so initially you assume it's the heart failure, but you always need to consider whether there are alternative differentials. The next thing you need to think about is why this has happened, because in the standard patient, they shouldn't start to decompensate, i.e. where they get an acute flare of their heart failure or they get pulmonary edema. And so the things you need to consider are, is the patient drinking way more than their diuretics are able to pee out? Is it that they're not taking their medications? Or is it that the underlying disease is getting worse? The next thing you need to consider is whether this patient needs to actually come into hospital to manage this, or whether they can be managed as an outpatient. So firstly, when we're considering the differentials, it's easy to assume that whenever a patient has overload or edema, peripheral edema, that it's due to their heart. And actually, in most circumstances, it is. But there are some things just to bear in mind that could be alternatives. For example, medications. So amlodipine is particularly the 10 milligram dose. The 5 milligram dose doesn't tend to cause peripheral edema, but the 10 milligram dose does. Kidneys. So one thing to look out for is whether the patient has got proteinuria, i.e. Can you quickly get a urine dip and check if they got protein? because that might signal to you that actually maybe it might be the kidneys that are doing this. And also you can check the U&Es to see if there's some renal dysfunction. Finally, the liver is something else that you need to consider. Essentially, the liver is an organ that helps in the digestion of food and in the manufacture of protein. And so, if your liver isn't working, you don't have as high protein levels. And so, instead of fluid being kept in by that protein, it leaks out. And so, if you've got a patient who you suspect might have liver failure, that's why they might have their peripheral edema. They tend to also have jaundice or ascites in addition to that to help tell you that it might be, or a background of excess alcohol intake to help nudge you towards it might be the liver. Assuming it isn't, and actually in most causes of heart failure, it really rarely is another cause. It tends to be very much the heart failure. You need to think about these three things to work out why the patient may have gone into heart failure. Because ultimately, that will help you with dealing with this patient. For example, is it due to increased fluids? Either because Beryl was drinking too much water or too much fluid, or that the diuretics are not enough or aren't working. So one really helpful question to ask Beryl is, when you take your water tablets, when you take your diuretics, do they work? Do you find that a couple of hours after, classically 2 hours after furosemide, that you're peeing out lots and lots of water? Essentially, if they're not working, then you've got your answer. You might find that you need to increase the amount of diuretics, particularly as patients progress, but also in particularly two circumstances. One, when they've got so much fluid that they've got fluid in their guts as well, which means the absorption of furosemide is poor. So if you find that they've got fluid all the way up to their to their thighs or to their tummy, or if they've got a background of kidney failure, because that might mean that the diuretics aren't as effective. It's always important to ask about compliance. And so the way that I always ask is, many people forget to take their medication from time to time. How often do you forget? And that will tell you whether it's because the patient's forgotten, Beryl's forgotten to take a diuretics, which is usually the most common cause for why this tends to happen. And then the last thing is disease. Is it that the underlying disease process has worsened? Is it that she has had, for example, another heart attack, which has made it a lot worse? Or is it just the natural history of the heart failure that it's been getting worse and worse and worse? And you can ask her that. Beryl, have you found that your medication, the amount of medications that you're needing to take have gone up? Or have you found that the fluid that you have on your legs has just been going up for months and months and months? And with that in mind, you need to think about whether she needs to come in. She might need to come in for some tests, because you're thinking it's possible that this is new onset of worsening heart failure from those previous questions you just asked. Or because you're unsure about what the cause of the heart failure is. And we need to work out the cause, because we need to make sure that if we work out the cause, that we can deal with it. The next thing you need to consider is whether the patient needs treatment in hospital, or whether they need to have blood tests or another reason why they need to come into hospital. So it might be that they need to see a specialist to quickly and rapidly adjust their treatment to prevent them needing to actually come into hospital. So for both of these circumstances, you might see the patient in either ambulatory care or a heart failure specialist clinic, whatever services are available to you locally. And then finally, you need to think about whether they need it for support. And that's really the biggest reason for why a patient might come in with heart failure. Their inability to manage their usual daily activities, because the amount of fluid has resulted in them being so short of breath, they can't manage on their own anymore. And so they might need an assessment for some short-term support, or essentially, if we can get the fluid off, then they can go back to their normal daily activities. The final thing to consider is if a patient is coming in recurrently with heart failure every 1 or 2 months, you need to start thinking about advanced care planning. Is it really right for the patient to constantly be coming into hospital, getting a cannula, getting blood tests, being away from their family? Actually, no. And so it's quite frequent that we'll have to have conversations with patients and say, look, the natural history of heart failure is that it progresses and that it gets worse and worse and worse. And at some point, we're going to have to think about when actually coming into hospital and having all of this fluid taken off isn't doing you any good, and it's actually making you feel worse. And so back to Beryl Freeman. Beryl, fortunately, in this situation, she does not need to come in. Her symptoms are mild. She's able to cope. She simply needs some advice, some bloods, and some medication changes. And so that can be managed in the primary care setting, or occasionally in secondary care via ambulatory care. And so her team will advise the following. They'll say, make sure you adhere to a fluid restriction so your diuretics have the ability to work. Something like 1 litre or 1.5 litres, and then we'll reassess. We might say, let's increase your medications. So that furosemide that you're on, 40 milligrams, let's double it to 80. Or that bumetanide, let's increase it by a milligram. And then once we've done that, Beryl, what I want you to do is I want you to do daily weights. I want you to weigh yourself every day so that we can see whether all of our interventions have worked. And we'll be aiming for about 0.5 to 1 kilo off per day. We may want to do a couple of further tests to work out why this has happened, but also monitor those UTNEs. We know that a small rise in the UTNEs is quite normal, up to 20%. But any more than that, we're just thinking, is this the right thing that we're doing for the patient? Ultimately, if the patient does have pulmonary edema or quite significant edema, you simply do need to increase the diuretics because essentially the kidneys will work much better when the heart is able to pump more effectively. And then the next thing we need to do is think about what we can do to stop it getting worse. So not only all those medications that I talked about, but the other things as well. Can we improve the blood pressure, the diabetes, the anemia, stop smoking, and also cardiac rehabilitation with a multidisciplinary team? So exercises and education to try and get Beryl better and more able to manage at home. But unfortunately, with heart failure, there is a chance that at some point you will get very unwell and you will need to come into hospital. And Beryl may reach a situation where she can't cope. And she may develop acute pulmonary edema. And so here we've got a chest X-ray which shows acute pulmonary edema. Often we use the kind of ABCDE approach to have a look at this chest X-ray. So A representing alveolar shadowing, B curly B lines, which you can just about see that little line that's crossing there. Not the one here, but that little line crossing there are the curly B lines. That's with a KER. C, that cardiac silhouette. So what we can find is that it's enlarged, it's big. We normally expect that cardiac silhouette to be less than 50% of this cardiothoracic ratio. And so here it's bigger than 50%. D, there tends to be upper lobe diversion. Essentially, when all of the fluid in the blood vessels gets very congested, then the blood vessels start to get a bit bigger to try and accommodate for all of that. That's quite difficult to appreciate on this chest X-ray, but usually you would find it up in these upper lobes, and you'd find that the blood vessels are a bit engorged. And then E for pleural effusions. And so what you'll find are the little ends of these diaphragms are slightly blunted because there's some fluid in there. But I think the biggest thing that you can find when you see this chest X-ray is this alveolar shadowing. Essentially, there is lots and lots of shadowing all over the lung fields. And that's the really helpful sign of acute pulmonary edema. That, and if you've got a patient giving that history, all of these extra signs are just icing on top of the cake. Usually most patients will have this quite florid appearance of lots and lots of shadowing. And so Beryl is very unwell. She's got significant peripheral edema or pulmonary edema that's required hospital admission. And so she's diagnosed with an acute heart failure exacerbation. And so what are we going to do? Well, we're going to try and find out what that causes, the underlying etiology, and monitor that renal function, expecting that a 20% rise of the creatinine is quite normal. As before, we'll also do all of that restriction of fluids and increasing medications and daily reviews to monitor the progress, particularly those daily weights. And at the end of the hospital stay, we will try and say, this is your dry weight. So Beryl knows next time that she can just weigh herself if at any point she's feeling short of breath, to know immediately that she's starting to get overloaded and has to call the GP to adjust her diuretics. That prevents that from happening in the future. But ultimately, the reason why she's in the hospital is because she's going to need oxygen and IV diuretics. We know that IV diuretics tend to work a lot more effectively. And once we get some of that fluid off and there isn't as much fluid around the tummy, then we know that the oral diuretics are going to be absorbed a lot better. And so what we'll do is we'll aim for a short stay until she's a bit better, the fluid has come down to the knees or lower, and so we can get Beryl back on her normal medications and continue at home, measuring her weight daily with support from primary care to make sure that Beryl is managed appropriately. And so what we need to think about are the really worrying signs. So there is a situation where you'll either see Beryl at home or in A&E or in primary care, and there are certain things that are just going to make us really worry about somebody's heart failure, really suggest that this patient definitely needs to come in to hospital and get it evaluated urgently. And so that'll include respiratory distress. If the patient is struggling to breathe, that means that she's not going to be able to cope for much longer. Significant hypotension is a worrying sign. So if the blood pressure is below 90 or particularly below 85, you're worried that essentially the heart has gotten to the point where it is working so ineffectively it can't even keep the blood pressure up. If there are severe hypoxia, so if the oxygen levels are very low, if the patient is shocked, again, not just hypotensive, but essentially she's cold peripherally and she looks really unwell, a touch drowsy, that's a really bad sign. Acute coronary syndrome, i.e. if the patient's having features to suggest a heart attack, essentially in our heart failure patients, they don't have much good functioning heart left. And so if they have a sudden heart attack, then, and that's not treated promptly, that might mean that they have almost next to nothing left at the end of that heart attack. I'm very worried if a patient's got severe renal dysfunction, CKD stage 3 or higher, particularly because the diuretics aren't as effective. And so overload tends to happen more and more frequently. And at that point, you need to consider whether continued admissions for overload are the most appropriate thing or not. And then finally, if the diuretics are not working. So you might find that you increase the patient's diuretics and they still tell you, no, doctor, I'm not peeing any more than I was previously. And that's happened very frequently to me when I've been in hospital. And at that point, you're like, okay, well, I can give them to you for IV for a bit and see if that's effective. But ultimately, you may reach a situation where the diuretics simply don't work. And you'll need to consider more advanced strategies, but sometimes they're not appropriate in a very frail or otherwise a compromised patient. And so those are essentially the things that we've learned from today. And so let's just go over them a little bit more, just go over them again, just to make sure that we've consolidated them properly. The first thing to think about is whether the patient needs to come in. And so you might ask the patient to come in for tests because you see that the patient has gotten worse suddenly and you don't really know why. You might suggest that the patient comes in for treatment. And this will be particularly relevant if the fluid is at or just below the level of the tummy, of the abdomen. because it's possible that the oral diuretics won't be as effective. They might also need treatment because, for example, there's a heart attack or something else that's the underlying cause. But the most common reason that a patient will come in is for support. And so that will be if they can't manage their activities of daily living. And so that's the thing you need to think and consider when you're talking to a patient. Are you able to manage at home? Is the key question to work out whether the patient needs to come in or not. The next thing to consider is the cause. It's very easy to see the patient as heart failure, make that diagnosis and sit there thinking, great, I'm an awesome healthcare professional. I have made the diagnosis of heart failure. That's excellent. But actually, the more important task is to think about the cause, because that's really going to be the thing that will help the patient in the long term. Is it that their heart failure is simply progressing? And it's progressing it to the point where they're coming in again and again and again? At which point you might want to think about advanced care planning, involving the palliative care team and having discussions with the patient and their family to say, look, the natural history of heart failure is that it gets worse. This is something that's irreversible and not curable, which means at some point, unfortunately, the heart failure will lead to a shortening of your life. And we need to prepare for that. Or is it that this heart failure has a new onset or a sudden onset? At which point we need to think about all the other causes, the differential. So could this be due to the kidney? Or could this be due to the liver or medications? Or is it that there's a possible underlying cause of why they've got heart failure, like their valve or their heart, they've had a heart attack? And so that's some of the things that we're considering. And then finally, we need to think about the treatment. We need to take an accurate history of how much the patient is drinking and try and limit them further, because clearly, however much they're drinking is often a bit too much, but we won't tend to restrict them below anything below 1 litre, because that tends to be quite a dangerous thing to do, and you often find the patient's creatinine or their renal dysfunction gets a lot worse a lot more quickly. You'll need to adjust their diuretics. And so basically you will need to increase them until we can reach a point where on those daily weights, the weight is going down by about 0.5 kilos, but also the patient is describing that they do feel that the diuretics are working. And then the last thing we need to do is consider a multidisciplinary approach. So not only, so for example, cardiac rehab, that's very effective and very helpful. And so it tends to be like a 12-week program of exercises and education, which helps the patient understand their diagnosis and make those lifestyle modifications, which will help them in the long term. And so speaking to physiotherapists and occupational therapists to get that home situation or work situation ideal way is helpful. Speaking to a dietitian, particularly about a low salt diet, is very helpful. Heart failure specialist nurses, so you can contact somebody should your heart failure get worse and you need quick adjustments of your medications or need to get blood tests. Speaking to your primary care doctor or speaking to your primary care healthcare professionals, because they can help support you with this. But then also that kind of biopsychosocial model. Heart failure, having a diagnosis where you're short of breath and unable to do your daily activities with the knowledge that things are going to get worse and worse and worse is very depressing. And so it's important to ask these patients how they are feeling and whether they are coping emotionally, because they may need a lot of help with that.